unless I hear of some real impairment that's going to harm the patient, I'm going to encourage that person. Okay, we're going to keep talking about this every week. Right? You're going to continue to see this person, and we have to figure out a way to help you understand and tolerate that ambivalence, because that's where you're going to learn something about yourself as a therapist, right? As the supervisee, maybe as a person, and continue treating the patient and not abandoning care or rupturing the relationship unnecessarily. Because I think a lot, I think we've talked about this in the group sometimes, young therapists or even experienced therapists, we can't tolerate ambivalence. We can't tolerate not knowing that it's going to be wrapped up in a nice little package and done with. Because to me, the supervisor is coming to me saying, I don't like my feelings. I don't like the patient that I'm having the feelings about, and I want all of that to end.
All right, well, thank you for being here. Welcome to the What the Fuck is Life podcast, episode number, I don't remember, 8 or something,
Yeah.
8, 9, 10, I don't
Yeah.
know, depending on if you count my individual videos. Chris Cannida, you are a licensed, Canada like the country, right? I'm pronouncing that
Spelt a little bit differently, but pronounced
right.
Canada. Yeah.
Okay, but you're not Canadian. It's
I'm
very
not
confusing.
Canadian.
No, from
Yes, born and raised.
born and raised. Licensed professional counselor, which doesn't capture all of you've put into it's your license, but it's not what you do. We're going to call you a psychoanalytic or psychodynamic therapist.
There you go.
And we're here today to speak to two things. One is the merch that we just discovered, and two, of course, is supervision and what the fuck has gone wrong with supervision in the field. It doesn't have to be psychodynamic supervision. We're just speaking to the good therapy supervision or good supervision that helps somebody cultivate their ability to become a therapist of whatever modality. So first number one, look at this shirt. So
Max has merch.
I have merch. It says, if it's backwards on my screen, but I'm told it's not backwards. It says WTF is life with Dr. Max. For the 50 viewers out there today, if you want one, I'll start a merch. I think it's a little early in the career of my YouTube career or podcast career, but the sweatshirt's very cozy and comfy. And so maybe we'll do mugs, or what else did you say, Chris? Maybe we could do
You
hats.
get hats and
Yeah, mugs,
yeah,
t-shirts,
yeah.
thong bikinis. Chris is very into, so we might do that as well.
Yeah. Max is not my analyst, so he wouldn't know that.
Yeah, exactly. Yeah, no conflict of interest, right? And this is all safe. Neither of us are being paid by
Anyone.
I don't know, Amazon. That'd be cool if they were, though. Apple could pay me if they want. But today, in all sincerity and seriousness, if you could maybe introduce yourself and a little bit of your background as to your orientation and even, dare I say, expertise about supervision, or the decades of your experience in, again, nourishing your continued education, which is really, really valuable.
I started out as an educator. I have a bachelor's in special education, so I was a
Okay.
special
I
education
didn't know
teacher
that.
for about 7 or 8 years, and I ended up teaching the students, and I hated the term, but it was the official term at the time, the emotionally disturbed students in the school.
Really? That was
Yeah.
the term.
That was the term. That was the official term for the class of students, which is horrid to me,
Yeah, that
but
seems a little.
it was. But so I have this, I'm not going to say the teacher in me merges well with being supervisor, but I have this thing in me where I like to see things grow. And so that kind of lent itself well to supervision. But when I was thinking about it today, my introduction to supervision came from that itch after having been a therapist for years of wanting to help other people become therapists. So it was just that natural itch to get back to that part of me.
But there's a meaningful distinction, and I want us to maybe jump back on this later in our episode. Is that there's a meaningful difference between treating a patient and teaching,
Yes.
and I think that's also something maybe it would be valuable for you to speak to. As I think that could be lost, especially on newer therapists or inexperienced therapists or people who have not done teaching, or for instance the professor who's the academic researcher in the field of psychology or neuroscience or something, and they've never done therapy.
Right.
And these are worlds that
Well,
probably
there's
should be
this,
more.
it's almost like I picture a Venn diagram, right? It's such a unique niche. And I think even supervision in our field is carved out very differently than any other kind of mentorship, or supervision in other fields.
Different than, you mean like a residency
Like a
or a mentorship
residency,
or a
yes,
fellowship?
or a fellowship, right? Because that is a lot of academia, right? And teaching, but for us, there's the whole relationship. And you're right, being somebody's supervisor is different than treating a patient, yet the relationship piece, there are some similarities to both. And I think those nuances, and I'm going to talk a minute about my own supervisor, right? Where it kind of went awry, but I think that nuance of relationship, that blurred line, I think it becomes a blurred line for some supervisors.
The right. I mean, before we get too spicy, right off the top of today's episode, those horror stories that really pervade the field, they transcend all the silos of treatment modalities, and you hear in sort of our listservs or our news of someone in essence exploiting the relationship.
Yeah,
And it's
yeah.
it's incredibly sad to say, but it's incredibly common, not in the sense that it's the majority, that's not what I mean, but it's more common than you would believe within the minority of people that are committing this sin or this act of exploitation given the relationship, and in turn polluting the frame, obviously harming the individual who's looking for help and understanding, and obviously not doing the ethical thing of maintaining a sense of careful and thoughtful neutrality in service
Boundaried
of the
relationship.
right,
Yeah.
in service of the therapist's development.
Yeah, yeah, and so that actually, um, I think of Carl Rogers and Gloria, but,
You're allowed to
y'all can
bring
look
them
that
in.
up. Yeah, y'all can bring them in. But for my own, I was thinking about my own supervision and what did I like about it? What did I think was good? What helped prepare me to be a therapist? There were so many things about, and then what dismantled it for me. There were so many things good about it. I worked in an inpatient children's hospital at the time, well, a hospital where I worked on the children's unit. So we did a lot of group supervision. There were 3 or 4 of us. Our supervisor, who I will not mention by name because he's probably not on earth anymore. It's been so many decades, but I thought it was really good supervision. And I'll be just transparent, I was at the time recovering from a pretty rigid cannabis addiction. Okay. And my supervisor was also a licensed drug and alcohol counselor at the time. And rather than in our individual supervision, and I didn't know this at the time, and this is a point I want to stress about being a good supervisor, your supervisee doesn't know and is not supposed to know at that time what all the boundaries, what all the procedural things are. So I didn't know he was crossing a line, but he began to treat me to help me be in recovery. He began to treat me as well, but he incorporated it into our individual supervision time. At this point now, I know that that shouldn't have happened. At the time, I thought, oh, he's really taking an interest in how wonderful it is I have all of this. Years later, I was reflecting on this person and I thought I would look him up and learned that he had lost his license to practice for a boundary violation. Now, I didn't know the details of it, but it made me begin to question everything I thought I'd learned and was good in the supervision. At that point, I couldn't discern, should I have really taken that to heart, or was that the wrong thing to tell me? Or I began after years not trusting what I had learned in supervision, and I was really disheartened by it. And so it got me to thinking, and what you and I were talking about before you hit record, that who the supervisor is outside of the supervision can make or break who they are as the supervisor in supervision. Whatever their continued journey is with their own analyst or with their own training as a supervisor. And I don't think there's enough. I mean, in Oklahoma, you can become someone's supervisor after only being licensed for 2 years. I'm thinking about 2 years after I got licensed, there was no way they needed to hand me somebody who was going to learn from me. 15 hours of discussing supervision, and then you're a supervisor, you're approved. And so I don't know that except for 3 hours every year of supervision continuing education, there is no other training for a supervisor here unless you go seek it on your own. So I was thinking about what else does a good supervisor do outside of supervision that impacts, whether positively or negatively, the supervision they are providing.
Well, it's even here in New York, New Jersey, I'm most familiar with, where I'm licensed and supervised. But even here, there are accreditations, Cifhy, I think it's called, and someone can correct me where I'm wrong. And it involves trainings, it involves some months of work for an LCSW or a master's level clinician, LCSW, LMHC, LMFT, I believe in New York, New Jersey, you have to do further hours on top of your master's to be supervisor. And certainly, yes, to be fair and sort of tolerant, it does confer or at least correlate with better supervision. But what we're here to talk about today is the reality that it doesn't make you a good supervisor just because you attended an extra 12 months or maybe 18 months of work, or you did 5 years of practice for your C from LMSW to LC, let's say, or you did your PsyD, which was initially 5 or 6 years, or PhD, what have you, or even MD. It doesn't automatically, I think, as we're discussing, it doesn't automatically make you good at supervising. And that conflation, and again, you could hit the ground running where you see fit, that conflation between treatment and training is one of the arenas you learn experientially and through the work of working with your own supervisor and of course with your own supervisee, that it is not exclusively or to the exclusion of that form of relationship, I should say, and becoming a patient. And to say that more clearly, what I mean is we forget that the supervisee is not a patient. And sometimes their needs, because of transferential and countertransferential dynamics and how they emerge, it can feel like, well, the topography or landscape of their own psychology or the anatomy of their own psychology is coming into the room. We need to help them understand their countertransferential reaction to this patient. How do we help them nourish that clinical skill to be able to interpret something that's not exactly in language yet, or it's raw in affect? At the same time, I'm not there to, be their therapist. Yeah. And that line is a very difficult dialectic to
Well, that line, I even notice that line if I am seeing a patient who is a beginning therapist or in supervision or in their internship, and I start to realize I'm crossing a line here. And sometimes I will even say that out loud and make it real explicit. The conversation is going to a different place. Let's move it back to where it rightfully needs to be, right? Not that I ever want to withhold information or withhold a part of myself like that, but it's a thin line. And so it can impact their treatment too if I move over and start becoming a supervisor.
So let me put you in the hot seat. What do you do in that circumstance of where you have a well-intended, which is often the case, younger therapist, and you're supervising, hopefully maybe a longer term case, you get to do 20 hours or 50 hours if you're lucky, whatever, with them, and you feel how much their own psychology is, dare I say, impinging or coloring or flavoring parts of the treatment, where maybe it ought to be, again, I'm using these words, but more neutral, or they're not experiencing parts of the transference because of their own, let's say, perceptive biases, but it has so much to do with the interweaving fabric of their psychology. In your experience, how do you negotiate that?
Well, the very first thing is I'm pretty explicit. I will say that out loud. I am likely to say that out loud.
Could you give us an example?
So if I'm the supervisor, you mean?
Yeah,
and with the supervisee, yeah, actually,
so if I said, I'll role play it. This is what other people do on podcasts.
Yeah.
I'll be your supervisor and I say, okay, this patient's really pissing me off. And I don't think it has anything to do with me. They're just mean to their kids. And I don't have any sympathy for them. Something, I don't know, something like that.
Oh, well, I'm not having sympathy for you either. No.
Yeah.
Okay. So see, that's where the line is, because if I'm going to be, in my mind, I think about what would I say if I was their therapist, right? Which may be very little. I may just let them continue, right?
Sure.
And what I do as a supervisor, I'm likely to ask more questions rather than guide them in any way for a minute. Wow. So when you feel yourself getting pissed, do you notice that it changes who you are for the rest of the therapeutic hour? Right. You notice yourself getting pissed. Does that change how you think about the client or your patient between sessions? Does it change what you may say or may not say?
I feel I'm going to continue.
Yeah. Keep going. Role playing.
Yeah. I in a past life, I was an actor, so this is fun. I'm so embarrassed doing this, but it's good to have this discussion. Yeah, I do think about them out of session because I frankly, Chris, I I'm so grateful for your help, but I don't really want to work with this client or this patient anymore. They really
Yeah.
bother me. And that's how
Yeah.
it makes me angry. I really do. You're right. I feel the anger, and it's not me. I can't help it. I can't help it.
Yeah. Right. Right. So if I can, I'm going to self-disclose a little bit as your supervisor. I'm going to share with you, I'm going to pull on some of the times when I was at that point, that fork in the road where I don't want to work with this person anymore. I can't stand this person. I see their name on my calendar. So I'm going to step out of role play and just kind of say, one of the first things I'm going to do is objectify or normalize what they're experiencing, right? Then I'm going to step back in and say, so I'm going to tell them about, this is a true story. I had a patient of mine fell kind of within the personality structure spectrum, maybe narcissistic tendencies. Couldn't stand this person, couldn't stand their name on my calendar, right? And I, first of all, called my consultant, someone I do consultation with, right? And we talked about it, and my consultant helped me. So I'm also going to applaud you, Max, for bringing it to supervision and being able to be transparent about your feelings about the patient, right? Because here's where we can start to maybe help you make a difference, right? So in my own story, I took it to my consultant, and my consultant, her name is, I love consulting with a woman who actually used to practice in New York, New Jersey area. Her name's Joan. And she backed up and helped me see it clinically, right? She helped me really parse out my personal, the transferential issues versus what's happening clinically with the patient. And she helped me think about my own patient in terms of, wow, do you ever think that your patient feels pissed like that, right? Maybe you're picking up on something that they feel as well. And in my consultation, I backed farther and farther away and was able to compartmentalize for the time being my own personal feelings about the patient. And guess what happened? I began to hate him less. I began to really see it more objectively. That didn't mean I didn't still have my own feelings about it, right? But once those were parsed out, I was able to then go to my therapist, right? And say, hey, there's this thing happening in me. Here are some times in my personal life that I feel the same thing. Because as the therapist, that might be what I would ask my patient, saying, I'm really pissed about this patient. Wow, have you ever noticed you feel those things in your personal life? That is not something I would pursue in depth with a supervisee. I would suggest they go to therapy and pursue the answer to that question with their therapist. Are
And
they?
do they, and speaking as me again and not
Mhm,
as your supervisee, do they tend to respond well to that suggestion?
mhm, mhm.
Even in all your experience, the
In all of my experiences, yes, except some of the ones I've had who were really anxious will still press me on, can't I just refer them out? Isn't it
right.
now outside my scope? Well, at that point, the supervisee in them is showing, right? Because they don't know all the nuances of what scope is or what it is. So there's an opportunity for me to teach them that's not really what scope means, or there's a transference issue or whatever. Here's what worries me most is when they don't have a therapist. Well, I'm not
Which
in
is
therapy, and
common.
this is common. I don't have a therapist. I don't really think I need therapy, and so we talk about that. Back in my day, we were required to go to both individual and group in my program, and that's just not a common thing for master's level programs anymore, right? I've had them ask, can't you just help me with it? I'm going to help you as your supervisor. Yes. And we talk about what do we do? How do you keep an awareness of self as the therapist? And how do you put self to the side as the therapist so that it doesn't impede the treatment with the patient? So there's that opportunity to take it back to supervision rather than being their therapist and maybe get more back into trainer or teacher mode.
Right. And it takes so much humility. And there's so many things I want to jump on there, but the first thing that comes to mind is the humility that it takes for the supervisor to negotiate this, tolerate, manage this reality that there could be a secondary gain, a desire to help and a desire to be therapist, a desire to fix, a desire to cure, a desire to feel effective. And in my experience, again, where I'm relatively speaking on the younger side of this career, despite a decade into it, the desire to help can preclude a more objective point of view, and you end up interpreting, even though an interpretation isn't needed or not necessary, or maybe it's even ham-fisted or cumbersome or what have you. And really what you're there is to help them, like you said, teach so as to understand. Most of it has to do with the transferential or countertransferential dynamics and the anxiety of the young therapist wanting to be effective and also not lose their, and this is in my experience too as a supervisee, not lose their, for lack of a better word, arrogance. And I mean that not as a pejorative. I mean that the way that I was taught sort of arrogance is incumbent upon things that do not belong. It's sort of etymological history. To arrogate is to sort of steal.
Mhm.
And confidence is endogenous. It's internally generated. And so when I was first starting out, I had this veil of arrogance to protect me, which I think every therapist does. And supervision and the suggestion of therapy before I was in long-term analysis was scare the shit out of me because I was going to lose any little bit of fragile protection I had, even though, because I didn't know what skin in the game was. I didn't know what actually being there was. I didn't know any of this stuff. So you can't blame, you know,
That's right.
I can't blame a young therapist for that anxiety.
Well, and that's what I was going back to. As a young therapist, I didn't know that my supervisor was pulling me in and crossing a boundary. I wasn't
Right.
supposed to know. I was the for a while director of admissions in a hospital, and I had most of my admissions counselors who did intakes and things for chronically mentally ill were beginning. They were either very newly licensed or they were still in supervision with a supervisor outside of that department, and sometimes they would get frustrated with themselves for not already knowing, right? Or for feeling unsettled with a particular patient presentation. And I have one, and I have no doubt that she turned into an excellent psychotherapist if she's still on her journey. But I would repeatedly say, "You're not supposed to know yet," right? And so one of the things I do in supervision with, like the presentation you gave me in role play, is to me my responsibility is to help them learn to tolerate the ambivalence, right? Unless I hear of some real impairment that's going to harm the patient, I'm going to encourage that person, okay, we're going to keep talking about this every week, right? You're going to continue to see this person, and we have to figure out a way to help you understand and tolerate that ambivalence, because that's where you're going to learn something about yourself as a therapist, right? As the supervisee, maybe as a person, and continue treating the patient and not abandoning care or rupturing the relationship unnecessarily. Because I think a lot, I think we've talked about this in the group sometimes, young therapists or even experienced therapists, we can't tolerate ambivalence. We can't tolerate not knowing that it's going to be wrapped up in a nice little package and done with. Because to me, the supervisee is coming to me saying, I don't like my feelings, I don't like the patient that I'm having the feelings about, and I want all of that to end.
And I don't like that reality is biting. So there's an intolerance for reality, which is quite synonymous with ambivalence,
Yeah.
obviously, the reality principle. And so they don't like the reality of the job. They don't
Right.
like the reality of the vocation and
Yeah.
even avocational components that, sort of are peppered into this work. There's a real, as I've discussed with other people on this podcast, there's a real, philosophical or ontological underpinning to this work that we have to be tolerant of in examining our own well-being, or what it means to be ourselves, what it means to be human, blah 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 blah. And if we're entirely intolerant of that, especially in the beginning, defensively, unconsciously, unwittingly, and we're compartmentalizing in such a way, or intellectualizing is like the most obviously common defense of the young therapist, or the trainee, or the someone in school, whatever form of grad school, because it is taught, academically, which tends to lean towards a cognitive or intellectual way of learning. And it's not, as Marotta would say, or Karen Marotta, how I always pronounce her name incorrectly, it's not multimodal. It's not inclusive of experience. You can learn how the bike works and take a physics class on it, but if you don't know the experience of riding the fucking bike,
Yeah.
yeah, you're missing a huge part of the
Well, and
information.
if you don't know the experience of riding the fucking bike, then when you're on the
Watch your
bike,
language, please.
if you don't know the effing experience of riding the bike, then when you're on the bike and you begin to topple, you're not going to know how to navigate that moment,
Right.
right? That
At all.
I'm about at all, that I'm about to fall. How do I keep my balance? How do I get back on track? Right. And so, the other thing I am likely to do with the supervisee when they bring those feelings is to help them see the feelings as rich with information rather than something to be disavowed. And, we talk about this all the time.
All
People
the time.
disavow.
I mean, Nancy, what does Nancy say? Nancy McWilliams, I'm on a first name basis with her. We text all the time. We got coffee this morning. But no, but she invite the hostility because you're inviting the information.
Yeah.
It is all information.
It's all information and curiosity. Because we know that even Peebles talks about, being curious can, number one, it can calm you in your nervous system, for the somatic people out there, right? Curiosity just starts to change how you're interacting with the emotion. Let me be curious about it. What is the information? Now, back in the role play, the supervisor might say, well, that doesn't help because if I get curious about it, if I say, where's this coming from? It's coming from me not liking the patient. And then in supervision, I'm going to get to model what might happen with them and the patient. I understand it's really strong emotion. Let's continue to look at it. Let's continue to seek, on a deeper level, what information it's giving you about the patient.
The safety, what you're reminding me of is the safety. Is something you're sort of putting a knot in my belly in my recollection experientially of, let's say, 9 years ago for me. And I remember that anxiety now that you brought it up of, okay, I'm going to examine. Now I'm not equipped with this sort of reflective functioning yet, even though I have maybe the ability, it's the capacity, but it's totally blind. It's
Developed.
underdeveloped. So I get what you're saying intellectually, but I would also limit myself in service of protection, sort of my own ego functioning or
Uh-huh.
ego integrity. And I'd say, okay, no, it is coming from me. I see what you're saying. I understand that it's information, that I'm angry or I don't like this patient or I can't work with them. But there's nothing else to be said. That's what I would say next. There's nothing. What do you mean? It's this guy sucks. He's mean to, making up the story again. He's mean to his wife. He's mean to his kids. He's unethical. He cheats on his taxes. He cheats on his wife. He pooped his pants in my office. I don't know. I don't like him. And so what do you mean, that you want me to?
Max, can we slow in we're more role play, right? Max, can we slow down for a minute and go back to when you first began to see this person, when he first began coming to see you? What was he coming for? What had you and shout out to Jonathan Shedler, case conceptualization, right? What had you and he agreed was going to be the work of the therapy? Let's slow down.
So if I were to be myself, then I would say it's just like I'm in a time machine now. I'm not gonna make that joke, but you're making me anxious.
You're
So
anxious
I
right
would
now.
say, I would say, what would I have said back then? I would say I wouldn't have So no, I wouldn't have done the Shedlerian thing of understanding kind of the 3 times oriented strategy of what brought you in, why now, and how do you think I could help you? I don't think I had, again, try not to ruin the role play here. I
No,
want to
you're
win
good.
I
Good.
want to win an Oscar for this, but I don't think I had the confidence clinically and genuinely because I wanted it to be told to me. This is maybe good for new therapists to hear because I was so anxious, and I feel a constructive pride admitting this now. I was so anxious that I didn't want to know what I was supposed to be providing them. So I wouldn't use a question like, I could use why now and being like, there's a chief complaint and intellectualize it. And I could say, how do you understand therapy could help you, and veil myself behind theory. But I didn't include myself, my own personality, my own style, my own skin in the game again. And I didn't have that access to that capacity of being what's the word, the conduit of this information through the transference of avenues of information.
Yeah,
And I was too afraid. I was so genuinely afraid. I feel it in my heart. Like I have such sympathy for people going through training. It's a hard
it
fucking
is.
process.
It is.
I was really I haven't thought about it in a long time. So I'm very grateful for this conversation. I was really anxious and I wouldn't want to admit that to my supervisor. So I would really veil myself in talking gobbledygook theory because I always liked it.
It sounds like when your patient comes to you, he talks gobbledygook too. It just doesn't show up as theory. It shows up as hubris. It shows up as, anger. It shows up as all of these other things rather than what's hurting and what he's suffering from. Assholes don't easily show us their suffering.
Right.
They show us the
They show us
veil.
their
They
assholes.
show
Yeah.
us the asshole, which I
Right.
can see far less of.
Right. Right.
Yeah, but they show us the veil, right? Yeah, rather than the suffering. Yeah. So, yeah, you're going to come to supervision and not show your suffering.
And that's another, I think that's an excellent way to say it. It takes courage on the part of the supervisee to show their suffering, especially when they feel unsafe, inexperienced, anxious, judged. I mean, so much, again, keeping it on the eye,
Yeah.
so much of my experience in my formal training, after really at institute training, analytic institute training, involved that I had to protect myself because I felt so vulnerable and I wasn't allowed to show that or experience that or illustrate that. I wanted to be, I wanted to rush through my training or something, some sort of claim like that. I'm not exactly
I'm
sure.
sitting here, two thoughts are coming up for me. Number one, I don't know that I've ever heard a lot of talk about, we talk about the mostly misuse or overuse of self-disclosure as a therapist to a client. But I don't hear a lot of people talking about self-disclosure as a supervisor. I mean, you're sitting here talking, and I'm sitting here thinking, well, Max, one of the things I would do as a supervisor is consider sharing exactly what you just shared with the supervisee.
Sure.
Right? Because you're right, the developed they don't have the developed ability to even the nuance of self-awareness and self-expression of what's happening with them in that moment. Where else I can't just say, well, Max, I need you to be really aware and have some, courage in self-disclosing. I'm going to have to model it for you.
But it's super right, and a supervisor might say that. So back to the top of the conversation today, the inexperienced supervisor or the well-intended or just the intellectualized supervisor who's been, and I experienced this at different not just the institute, clinic, university setting, doing all my education, where they've been doing it for 25 years, but they never themselves, because of, right, we've spoken to the blind leading the blind, and their process is intellectual and interventive, and, I won't say manualized per se, but
Yeah.
it's
It's
it's action.
it's
It's
action.
action based. And so they were never tolerant themselves of understanding what was behind the veil, the man behind the curtain or the woman behind the curtain for they themselves. And so you'd be told from a supervisor, did you try this? Did you do this? Did you ask yourself about this? Try coping, with that feeling, or maybe even they would try to neutralize it for you. Don't worry about it. That's a normal feeling. You're supposed to feel that way. And then let's get back to the patient and their concern.
Right. Well, that's interesting. I was providing some mentorship a couple of years ago, and the person she'd come to me for consultation. She wasn't quite ready. She hadn't taken her national board exam yet, so she couldn't enter supervision yet, but she wanted some consultation on some cases in her internship. And she kept asking me, I forget the case of the client, what do I do in that moment? I don't know what to do in that moment. And I know she got frustrated with me because often I would tell her, how about nothing? How about doing nothing overt? Right? And it would just drive her nuts. What do you mean do nothing? So what am I supposed to do in the doing nothing? Listen, wait, silence, quiet, whatever that is, because you're right. They want to do something to resolve those feelings of, I'm pissed at my patient. I don't like my patient. I want the patient to go away. Or I want my feelings to go away. Because can you imagine a young therapist experiencing that for the first time? I've entered this field. I'm now jumping into, and oh my, and because a lot of therapists have that, I'm going to save the world. What Marotta say, I'm going to save the parents I couldn't save.
Right, right.
You know, I, and I didn't expect to have negative feelings about another human being. I expected to love them all and have all the what Nancy McWilliams would call manufactured. I love how she uses accurate empathy. It's not manufactured as a tool, but it's coming from the person. And so when they run into this wall of, there are some human beings I don't really like, I don't want to save them. They piss me off every time they come in my office. That's a pretty scary place for a therapist to be. Because if I can't feel good about them, there's this equation. If I can't feel good about them or empathic about them, and by the way, empathic doesn't mean just understanding or being able to imagine or feel their positive or gentle emotions, but the harsh ones too, then how can I help them? There's this built-in unspoken equation. I have to feel good about them to help them. Now, maybe I'm going to help them by being pissed, but sticking with them anyway.
It's such it's a wonderful way to put it. It's wild to me being here now. I mean, again, when I was I'm half 25 in today's session, but it's wild to me today that that's so lost. That conflation between performative or manufactured or prefabricated empathy and actual empathy, as we were just saying, especially in the the prerequisite need, a bit redundant, but prerequisite need for the supervisor to know the difference. And
That's right.
if it's lost on them, they're not going to be able to provide supervision in any meaningful or comprehensive
Because
sense.
I might blow the supervisee's mind and suggest to them that the anger they're feeling might be coming from their empathy.
Right. And they're going to say, what the fuck, dude? What are you
What do you
talking
what do you
about?
mean? Yeah, well, because let's break down empathy and what it really
Right.
is,
Right.
right?
Right.
But there is my one of my golden nugget moments as a supervisor. I'm going to introduce them to an idea or a way of looking at something that they had never considered and probably didn't get from a textbook, right? Because especially the way we're kind of pumping out these degrees and therapists these days, where's the slowing? The biggest lesson I ever learned was from Mary Jo Peebles' book When Psychotherapy is Stuck.
Right.
And I think and I try and I apply some of those principles if I'm thinking about supervising. All the same, the awareness and all the things she talks about.
With the fastest way. I think that is one of the most timeless and most effective lessons you learn experientially, is the fastest way through any treatment is slowing the fuck down.
Slow the fuck down,
And
yeah.
it's really uncanny when you internalize that as a supervisee and as a supervisor both. When you start to internalize that to the point of it being integrated into your own clinical or psychological anatomy, personally or professionally, and you can feel yourself giving space to, or giving light to, the information that's held within the microsecond or nanosecond or silence or nonverbal communication or implicit empathic attunement, whatever you would call it, and you're nourishing that, it's night and day. There is, for lack of a better phrase, there is no stuckness, or there's no burnout. There's no friction, even though there's going to be still all the complications and complexities of those feelings and emotions and sensations that are all emergent in the space between, you and the patient or client, or you and yourself, or the patient themselves. But if you're available to it because you've slowed down, the work is it, I feel a little self-conscious saying this as if it sounds cocky, but the work doesn't really get so stuck. Or at least that's certainly a meaningful inoculation to stuckness. Maybe it's not a panacea, but it really, in my experience, it's much harder to get stuck if you are in the here and now and slowing down and feeling with the supervisee who's in a stuck case, or your own patient, and honoring essentially what's going on right in that moment with the
And
entire.
you just beautifully, I'm sorry to interrupt, you just beautifully
I know, and I was on a
described
roll.
butter paradox. If I slow down, I'm going to end up opposite of stuck. I'm going to be moving through it. People even breaks it down to like these 5 steps: the slowing down, the registering what's happening, the noticing, the tracking, and then being able to express it, right? I think we can apply that to supervision,
Yes,
modeling it
very
for the
much.
supervisee. Also, if I can't accept, kind of back to your role played therapist, if I can't I have to learn to accept my own emotions in order to accept what my patient is showing me. And I don't mean accept as, oh, it's okay. Of course, the world is bad and you're all good. And oh, yes, go be angry and piss off your wife and beat your kids or whatever. No, you said the word available. If I have to be able to make space available to understand my own emotions so I can make the space available for all of their emotions.
Another phrase, and just recent supervising therapist that just came to mind, of what we call being ahead of the patient, or but it's being ahead of the supervisee is the same thing. And if you're ahead or behind, however you kind of orient yourself on this landscape, the reality is, if you haven't done the work internally on yourself, and the patient needs require an availability and attunement and understanding experientially, a capacity to hold, the list goes on, and you can't do it because of your own defenses and their strength, or because of your own rigidities, or because of your own anxieties, or because of whatever ego defense. I mean, that's another source of burnout or bad supervision. I've experienced on both sides as a supervisee and supervisor, where inability to, not only, I don't want to say tolerate ambivalence, but tolerate, it's almost to say like anxiety, yes, ambivalence, yes, tolerate.
Humanity.
Yeah, humanity. You can't even sit in it. Like, yes, it's uncomfortable. Like, you can't just sit in the kind of festering acid bath that it is. Well, don't do the fucking job. It's kind of
That's right.
wild. It's kind of, again, I don't mean to, it upsets me, not so much of being a little bit funny, but it does upset me in the sense of, then you can't do the work. It's not psychotherapy. I like the Jim Hollis thing of I always go back to that, of healing of the soul, what it literally translates to. Then you could provide coping, you could provide modeling, you could provide self-care in the kind of contemporary sense or the social media influencer sense, but you're not fucking
None of
helping
that is.
somebody heal.
Yeah.
You're not helping somebody heal. And if you're doing their supervision, back to our conversation today, it's like, it seems a sin. It really does bother me because, as we've talked about outside of this recording, the proliferation of bad supervision, not to say we have a monopoly. I could hear the trolls. I don't have a monopoly on good supervision. I'm just saying you better be in your own treatment for a long time before you can provide
Well,
meaningful and in-depth supervision.
and to help, imagine being the supervisee, reaching that point where, okay, I've gone through school, I've passed my board, I've gotten approval to get my supervision, and I find out that there's this whole piece of being a therapist that I don't even, number one, don't think I can do, or it's going to be really difficult and I don't want to do, but I just poured all my finances and time
Right.
into this
Yeah.
training. And then it's like, oh, heck, what do I do now? So I think as supervisors, part of our responsibility, and I'm not so sure I'm really great at this, right, is to help them even tolerate that and not make a rash decision. Right? There's something to be gained from being at that fork in the road, right? Because
To
guess what?
live in that space of discomfort. Yeah.
Because guess what? Most of your patients are coming to you with some version of that fork in the road. And how great it is that you can, because where does empathy come from? Being able to access that thing in ourselves, right? And then you can offer some real understanding of what it's like to be going in that oh shit moment, because you've been in that moment and maybe are actively there as well with them. Yeah.
Right. I was going to say, and then the difference in the real empathy, accurate empathy, best approximation of somebody's lived experience or what it is like to be empathy is that you're part of it. I think what you were bringing up sparked in me so valuable was that you could be in the transferential dynamic, or in the, just call it the relationship, so that somebody doesn't jump down my throat and say transference isn't real or something. In the relationship, I'm going to be a part, an element or component at the most fundamental level, at the ground truth bedrock of their psychological anatomy, a part of, by feeling through that information that they're displacing or disavowing, I am going to be able to empathize, not because I'm pretending to be what it's like to be them, which is arrogant to a degree, but rather that I'm actually experiencing a part of them that they are displacing, projecting, disavowing, identifying, etc. And so my reflective functioning and maintaining some form of blank canvas, neutrality, thoughtfulness and carefulness, not cold neutrality, but I'm then going to reflect that back to the supervisee or the patient in a way that helps them either do the job of being the patient or the supervisee. And I'm going to do the calculus, like you were saying before, in the arithmetic of knowing when it's appropriate for the supervisee and when it's not. Because I think something else, tying all these things, loose ends together, when I experience such meaningful and moving, transference or countertransference with the supervisee, like I was genuinely asking you before, it can be so challenging to negotiate because I don't want to bite off more than they can chew for them. And I also want to stay in the role of the supervisor. At the same time, it's quite clear to me that their own psychological makeup is playing a large role in, let's say, a misattunement or a misinterpretation or
A lack of tolerance for their
a lack
own
of tolerance.
emotional,
Right.
emotional
And
feelings.
so having to not be their therapist, but also help them see, but also not intellectualize, but also not interpret. It's
But
a
see,
hell of
that's
a,
that's why I think that supervision in our field is such a specialty, because number one,
yes.
you have to be able to understand all those things where and tie it all together, and then be able to articulate it to them,
Yes.
and not cross those boundaries of becoming therapist, but stay supervisor. Right? There are so many intangibles and tangibles that come with being, I think, I don't want to say just being, but providing good supervision. Right?
It's really, yeah. And it back what I was saying before about what it's like for, at least in New York and New Jersey, with the licensing boards and how out of touch they all are, of course.
Yes.
But this idea that you can get this, again, I think it's called a Cifhy, and then that in this automated, like appeal to authority type of way. You put it at the end of your last name, you have more letters, and now you can provide. In my experience in those classes, just keeping it on the eye, they didn't speak to much of the intangibles because it's hard to didactically and pedagogically, if that's the word, I understand and sympathize with how difficult this stuff is to teach to somebody wishing to become, well-intended, again, a decent person, a good supervisor. And how do I teach to them without the intimacy of one-on-one, if it's a classroom as an example, or the intimacy of their own therapy, or so on and so forth? Those aren't necessarily
Well, there
prerequisites.
you go, the intimacy with self. I have to know myself intimately, right, to be able to communicate that or share that with someone
But it's
else.
not taught that way. Again, my experience, it's taught as if it's an intellect. It's taught like any other form of healthcare or medicine. It's taught out of the book. And you read this chapter, then we're going to have the discussion, then you're going to write the paper, then you're going to do the practice with the patient. And again, you do learn stuff, but if that X factor is always going to be missing if it's never brought to your attention. That known unknown and those unknown unknowns are always going to be percolating. And if you deny them because you got your letters after your name, you're going to have a bad fucking time.
Well, and learning something and living something is a different kind of
Right.
learning,
Right.
right? Yeah, yeah.
It's really uncanny. Yeah, I'm getting hot. And my merch.
I gotta get one.
Yeah, it's the only one. It's a one of one. So if I do put it on eBay, maybe I'll sign it. Make some money. I'll
Yeah,
pay for the podcast.
there you go.
It's really funny. I have a lot of sympathy now after this conversation today for those who teach. No, so maybe I could ask you this question: do you ever teach supervisors or consult in helping them become better supervisors? And my question is, how do you teach it? What's your experience?
That's a great question. I have not.
Okay,
Okay, I have not, but I was thinking because I just did the little workshop on the therapy frame, right? Where that putting, that's part of my own individuation, right? Is to assuage my own fears of putting myself out there. And I was thinking, what am I going to do this year? What am I going to develop this year to maybe put out there? And now I know.
we did it.
Now I know, right? I mean, I'll
I
wear
get.
I'll wear the Max T-shirt.
I would say, well, I get a kickback. It's 10%.
Yeah, right, right, right. No conflicts of interest. No, but that doesn't happen. Aside, I mean, we're required in Oklahoma to take 3 hours every year of supervision, right? And so I just took one, and I was sitting there the whole time thinking,
Are you allowed to say how it was, or is that I don't want to put anybody? Can you be diplomatic and
here's what I'm
euphemistic?
going to say. Sometimes I think I'm really unfair in evaluating somebody who's maybe only been in the field 10 years or so because I've been in it for so long. I have my built in biases, right? And so there were some things that I thought were really good and on point, and then there were some things let me say this, it didn't include any of what we talked about today, right?
No intangibles, no.
Not
Like,
really the
yeah.
intangibles at all, right? And so, but like you said, I'm going to have to think about how am I going to articulate those and walk somebody through what that would look like in supervision in a structured way that I could teach somebody that. But I think it's a wonderful way. And look, I will say this: I was one of the people that presented a case to Dr. Shedler when he was doing a webinar or whatever in Ireland, and I thought, what am I going to learn by presenting this case to him? I walked away, and the lessons in my reflections just kept coming for multiple days. So how would I, so my husband asked me, so what did you learn? How did you learn it? What did he teach you by doing that, simulated case consultation? And I was stuck. I don't really know how to put it into words yet. Hence, I'm going to go back to the slowing down. I've got to really slow down and reflect. And then I have to see what would be in my way of going and teaching it to somebody else, my own personal psychology, my own struggles with individuation.
Right. It's really a fascinating domain or niche that maybe hasn't been. I'm sure somebody on the listservs or nationally, internationally has done a group on with other supervisors
For
on teaching
sure.
supervision. And I'm sure there's articles we could find. Nonetheless, intrinsically, it remains difficult to teach. Again, inherently, because it's incumbent upon those intangibles, these
Yeah.
ineffable qualities, these things that you that are experientially derived and learned, and they don't lend themselves to be symbolized in language or the word itself as an emblem or symbolum or a vessel. It can only capture a certain percentage of it.
Well, and I think of the term analytic attitude, right? I think of, well, strike that. I think of, when we talk about who the person is, who's the person as the therapist. I think we have to apply that to who's the person as the supervisor. because that's going to make or break. I can teach all the principles and foundations and things in the world, but if the person in me doesn't lend itself well to supervision, then I'm not going to do them any good. One of the biggest complaints I hear from younger therapists or therapists starting supervision is that when they have a complaint, there are good supervisors. Don't get me wrong. There, I hear great things about certain supervisors, but one of the biggest complaints is all they do is pat me on the back and tell me I'm doing a good job. Now that gives me a lot of hope in the generation of up and coming therapists, because even they sense I'm supposed to be getting something more and I'm not getting it. So that gives me hope, but then how do we help those people go find that thing? And how do we help them put words to what they're not getting? They sense it. It's an intangible at this point. How do we help them reflect on it so they turn it into a tangible need they can express out loud and admit to out loud, right? Going back to you feeling scared to, I don't want to
Yeah.
admit that I need this or that. Yeah.
Yeah, it's again thinking back of what I was so anxious about or so afraid of and what would have been helpful. Excuse me.
Father, it's
We're going.
there. We're going.
So what I was saying is that what it reminds me of is that anxiety, and how I think it was so much more powerful in hindsight looking back on it than I realized. And how do you teach what, like you said, if the person as the therapist or person as the supervisor, I was so, or supervisee, so anxious. And in that state, just to echo the limit, what you're saying, insofar as the limitations that'll always be there was nothing you could have done in terms of, I could have attended your incredible workshop, 12 weeks long, and seminar on intangibles and all, but I wasn't equipped, I wasn't available or amenable to it. And so it's such a tough pill to swallow, I think, that as
Well, that brings to point to, as the supervisor, what came up for me is there a point where the supervisor has to say to the supervisee, I'm not sure there's anything I'm going to be able to tell you or do in this moment that's going to get you to this place you want to be where you're not feeling this. The reality is you're going to feel this.
and that takes it takes huge balls. I mean,
Yeah.
again, I think, and we're so averse as a field, as a community, to aggression, to hostility, to self-advocacy, to our own self-worth. And so, again, as Murata says, right, when we default to these depressive, morally masochistic, self-depriving positions as therapists, the most of us are. There's very few expansive narcissistic therapists because they wouldn't want to help people.
Yeah.
And so, I mean, there's a selection bias that makes us kind of bad in a sense at becoming who we are or discovering who we are. And so that selection bias plays a big role too.
Sure. Sure. I think, I think we all in training had to write the position. I had to write what they called a position paper about why do I want to be a therapist or go into this field? I think that's a great question to ask anybody. Why do you want to be a supervisor?
Right.
What
Right.
is it driving that thing in you? Or is it just to make extra money?
Right.
What is
Or
driving?
the appeal, again, keeping it on the eye, I thought it was appealing as a sense of authority and a sense of power. And when I was really, really first starting, my early 20s, and I was so impressed by those people who had their masters done, and I wanted to be that. And that was part to do with, of course, my own psychology. And that was, very challenging.
Well,
And
that's where mine plays in when when it went from, hey, you have to be licensed for 10 years before you can do it, and then it knocked it down to 5, and now it's 2, and it's like, what an ego hit. So I'm not, there's
right.
no
Special.
distinguishing me,
Yeah. Yeah.
right, after for 35 years of experience versus the person who's had 2. So
Right.
what,
Right.
now where do I go to get that need of mine met,
I
right, to
think the
distinguish me?
I think what's also you're bringing to mind, and maybe we could discuss this in supervision, part 2 in our next episode, is that we're bad, not just the selection bias thing we don't acknowledge, but we're also bad at acknowledging that some people ought not or should not morally or ethically be supervisors or
Right.
therapists or whatever. And that in other field, I don't know if it's the same, the weeding process in healthcare, becoming a physician. Is it the same thing where somebody's in emergency medicine and then they can't hack it, so they end up becoming a gastroenterologist or an ophthalmologist? Or I don't know enough, but being very familiar and intimate and steeping in this field, boy, oh boy, does it seem like the bar is pretty low, and anybody can become any part of this if you attend the hours sort of the performative stuff again. You manufacture the time and you do it and you go through the motions, but you don't actually internalize, let alone integrate anything. And I don't know how you fix that or
Well, I love
deal with
this
that.
conversation that we've had, and because what it has done is highlighted for me the depths of what else we have to consider.
Was that loud?
Welcome to What the Fuck with Dr. Max.
Yeah.
Where we merge
Welcome.
housekeeping and therapy
Yeah.
in a digestible form.
Yes. We're tolerant. This is my exposing me to my frustration tolerance.
There you go. So yeah, what a great conversation. Because
Yes, thank you so much. This was so wonderful. You're a great improv partner, so thank you for that. And I can't wait. Yeah, we're going to do the next one. But next time you have to come with your whole plan of your 16-week course on how to teach actual supervision.
Well, there's
No pressure.
actually a curriculum you have to do in Oklahoma, so it's kind of prefab, but
Great.
I'm sure you can add your own stuff to it. So
All right.
I'll start small.
Okay. I will see you soon.
All right. Take